Exchange transfusion or blood exchange is a life-saving procedure and is necessary to be done when an infant's blood contains dangerous levels of toxins, abnormal cells, or antibodies that cannot be treated by other treatments. So our first goal in this intervention is to rapidly remove toxic substances, correct any imbalances in hemoglobin level, like what happened in severe hemolytic anemia or polycythemia. Polycythemia means increase in the number of red blood cells, and all these are necessary to prevent any neurological damage or any multi-organ failure. In this infant, there was high level of unconjugated bilirubin in the blood. Bilirubin is a pigment that has been produced in the liver. It can cross the blood-brain barrier and causing kernicterus, or in another word, it can cause permanent brain damage. So it is really important not to let the bilirubin to remain high in the blood and exceed our specific threshold. This threshold in infants is more than 25 mg per deciliter. The first step is to prepare the umbilical site and clean it with an antiseptic solution. Routine sedation is not recommended for most infants in this procedure because their liver is not mature enough to metabolize the sedatives well. But we should consider comfort and pain management. So we can use different ways, like positioning to reduce stress, use oral glucose drops for its analgesic effect, by its endogenous opioids effect, or pacifier sucking for its calming effect. After all this, we first use an anesthetic like lidocaine to numb the umbilicus so the baby will not feel any discomfort.
Catheter كامل يبندو دانيها
Now it is time to insert the umbilical vein catheter, that is a tiny tube threaded into the belly button vein. The tube must be soaked with heparin before entering the vein, so it prevents any possible clot forming in the tube. The first 4 cc of blood is necessary for diagnostic purposes. It should be sent to laboratory and be used to determine several parameters like blood grouping and cross-match, hemoglobin and hematocrit, bilirubin level, complete blood count, serum glucose and serum calcium level, direct Coombs, and other required tests which is different for any patient. The baby should be kept under a warmer with monitors to track heart rate and oxygen saturation during all the procedure, so we can understand if any unusual change happens over the intervention or not. The umbilical catheter must be secured to the umbilicus during the exchange transfusion for safety, accuracy, and continuity of the care, because during the exchange we use catheters several times to inject the fresh blood and remove the toxic blood from the body. And also, if the tube is not fixed, it may cause frequent movement and increases risk of infection and mechanical complication. After fixing the umbilical tube, we are gonna prepare other necessary equipment like 3-week cannula, sterile gauze, and discard bag to collect toxic blood. Discard bag should be fixed to somewhere below the umbilicus so we can easily withdraw the blood and push it there. Probably the best place we can use for this is the patient's bed. There are 2 holes in the top of the bag, one on each side. We pass a strap through each and tie it to the bed. Then we bring another tube and connect one end to the discard bag and the other end to one of the 3-way stopcock's outlets. The second outlet 3-way stopcock is connected to umbilical vein tube, and the last outlet will be connected to the fresh blood. We use irradiated O-negative blood mixed with plasma to match baby's need. After connecting all tubes to the 3-way stopcock, we are gonna slowly withdraw 50 ml of baby's toxic blood into a syringe and push it into the discard bag. It is really important to do this really slow and not remove more than 20 ml in any cycle. 2 to 4 minutes is the safe and typical duration to withdraw 50 ml of blood. Once we have removed 15 cc of blood, we rotate the head of the 3-way stopcock until it falls over the entrance of the blood bag, and then we push the blood into the waste bag. Once again, we rotate the head of the 3-way stopcock to get access to fresh blood bag. 50 cc of fresh blood should be aspirated into the syringe, then injected to the baby's body through the umbilical catheter. Now we start over again and repeat the cycle. In every cycle, we remove 50 cc of bad blood and get the same amount of fresh blood to the baby. Actually, the amount of fresh blood we are gonna use and the cycles we are gonna repeat totally depends on the baby's weight and the type of exchange. We use double volume exchange method almost all the time. The goal here is to replace twice the baby's blood volume. And how do we calculate the blood volume? Here we use an estimation. Basically, the amount of body blood volume per 1 kilogram of the baby's weight is about 80 to 90 milliliter. So the total amount of exchange volume is double, means 160 to to 180 milliliter per kg. So if the baby is 2.5 kilogram in weight, total exchange volume is about 400 to 450 milliliter, and if the baby is 3 kilogram, the exchange amount is 480 to 540 cc. We divide these amounts by 15 cc to see how many cycles it takes to exchange this volume of blood. Our patient here was about 2.7 kilogram, so we needed to repeat his cycles for 30 times to reach the goal, and it actually took about 2 hours to finish it. Sometimes exchange transfusion should be done twice daily to prevent any possible complication.
نبوي فعلا هنا كان وجهين جعله يجي خمسة شسبكي شو عماده بجعله طب أنا خافية بيوصل قبل ما أخينا بيني أو جاء ما أخيشني عبانو كردانا يكتانا تري شوية كلها ما بداية إيش ما خدوا الغاز وزن العين بعزي كينو شو دي شو كنيسة إيش أما شدي بخينا سري يكتانا غاز بخينا سري تركازي كأني نباني هربا موديل شايتو أنا بملا إيرا ما أعطيك إيش تشسب